All right, let's jump right in. Today, we're going to do a deep dive into the fascinating world of renal autoregulation. We'll be focusing specifically on the incredible machinery of the juxtaglomerular apparatus and the elegant little feedback loop it runs, known as tubuloglomerular feedback. These two things are really the bedrock of how the kidney maintains its own stability.
So here's our game plan. We're going to build this story from the ground up, from the microscopic anatomy all the way to the clinic. First, we'll get to know the key players in the juxtaglomerular apparatus. Then, we'll look at the kidney's unique blood supply, which, and this is key, creates a state of natural hypoxia. Once we have that context, we'll break down the tubuloglomerular feedback mechanism step by step. And finally, we'll see how this all plays out in real disease states and fit it into a broader framework for thinking about kidney disease.
Okay, first stop, the juxtaglomerular apparatus, or JGA for short. You can think of this as the kidney's own internal command center. It's this beautiful little anatomical structure where the kidney's plumbing and its blood vessels meet to control everything.
So, what exactly is the JGA? Well, it's all about location, location, location. It's this highly specialized bit of tissue sitting right at the crossroads where the afferent arteriole, the vessel bringing blood into the glomerulus, physically touches the nephron's tubule. And this isn't just a coincidence. This precise arrangement is what allows it to taste the fluid in the tubule and then immediately turn around and tell the blood vessel to tighten up or relax. It's how it controls both renal blood flow and the glomerular filtration rate, or GFR.
The JGA is made up of a few key cell types. The first ones are the juxtaglomerular cells, sometimes called granular cells. Now, these are really just modified smooth muscle cells sitting in the wall of that afferent arteriole, and they act as tiny baroreceptors. They sense pressure. Their main job is to make and release renin, which, as you know, kicks off the whole renin-angiotensin-aldosterone system. So what makes them release renin? Well, three main things. 1, if they feel less stretch, meaning blood pressure is low. 2, if they get a chemical signal from prostaglandins. Or 3, if the sympathetic nervous system gives them a nudge via beta-1 receptors. The second key player is the macula densa. Now, we have to be really precise about its location because this is a common misconception. These cells are not in the distal convoluted tubule. They are a plaque of specialized, tall cells right at the end of the cortical, thick ascending limb. And their function? They are the chemoreceptors. They're constantly sampling the tubular fluid that flows past, checking its ionic composition. And while they sense sodium and potassium, the main thing they're looking for is chloride. The chloride level is their best indicator of the total solute load reaching the end of the nephron.
And rounding out our JGA trio are the extraglomerular mesangial cells. You might also hear them called Lassus cells or Pulkisson cells. To be honest, their exact role is still a bit debated, but we know they provide the structural scaffolding that holds the whole apparatus together. They probably also help the JG cells and the macula densa talk to each other. Think of them as the support crew and communicators for the JGA. Okay, so we've got the microanatomy down. Now let's zoom out and look at the bigger picture of the blood supply. You see, the way blood flows through the kidney isn't uniform at all. It actually creates two very distinct functional zones, and this has huge implications for both normal physiology and disease.
Let's trace the path of an oxygen molecule. It starts in the renal artery, which is an end artery. Not a lot of backup circulation here. That artery splits into segmental arteries, then into interlobar arteries that run up between the renal pyramids. At the top, they arch over to become the arcuate arteries. From there, smaller interlobular arteries shoot up into the cortex. And finally, branching off of those are the all-important afferent arterioles, each one feeding a single glomerulus.
Now, what happens after the blood leaves the glomerulus is pretty special. It exits through the efferent arteriole, which is a key part of the kidney's portal system. And what's a portal system? It's just a vessel sandwiched between two capillary beds. The first bed is the high-pressure glomerulus for filtering, and the second is a low-pressure network for reabsorption. In most nephrons, this second network becomes the peritubular capillaries that wrap around the tubules. But in the deeper nephrons, it also forms the vasa recta, these long hairpin-shaped vessels that dive deep into the medulla.
So, because of this whole vascular layout, you get a really dramatic oxygen gradient. The cortex gets about 90% of the blood flow, so it's very well oxygenated. The partial pressure of oxygen, the PO2, is sitting pretty at around 70 to 80 millimeters of mercury. But then you look at the medulla, and it's a completely different story. Down there, supplied by the vasa recta, the PO2 absolutely plummets. We're talking just 10 to 20 millimeters of mercury. And the consequence of this is huge.
It means the renal medulla is always living on the edge, in a constant state of borderline hypoxia. This makes it the kidney's Achilles heel. Structures deep in the medulla, especially the hard-working pars recta and the renal papilla, are incredibly vulnerable to any further drop in oxygen supply. They're the first to suffer during an ischemic injury.
Now, because of this inherent vulnerability, the kidney needed to evolve a really robust way to protect itself. And that brings us to the very heart of our discussion today, the core mechanism that defends the kidney from being overworked and damaged. It's called tubuloglomerular feedback.
The TGF cascade is just a beautiful, elegant loop. Here's how it works. Step 1 is sensing. The macula densa detects that too much salt, especially chloride, is flying by. Step 2 is signaling. In response, it releases ATP, which is quickly converted into the key mediator, adenosine. Step 3 is action. That adenosine floats over to the nearby afferent arteriole and makes it constrict. And step 4, the result. Constricting that incoming pipe reduces the pressure in the glomerulus, which causes the GFR to go down. It's a perfect negative feedback loop, designed to put the brakes on when filtration is too high.
So that's the physiology, but how do we actually see this happening in a patient? Well, it shows up in their blood work. Since creatinine is a waste product that's freely filtered by the glomerulus, its level in the blood is a great inverse marker for GFR. When TGF kicks in and GFR drops, serum creatinine goes up. That rise in creatinine is the clinical signature of this process in action.
Okay, now let's apply this framework to a couple of real-world clinical situations. Let's see how TGF behaves during acute tubular necrosis and how it responds when someone is volume depleted.
Acute tubular necrosis, or ATN, is a classic example. It typically happens in phases. First, in the first day or so, there's the injury. Let's say a patient gets a toxic dose of the antibiotic gentamicin. The tubules get damaged and can't reabsorb salt and water properly. All that extra stuff gets dumped into the urine, so you might even see polyuria. But then, a few days in, the intact macula densa senses this massive solute load and freaks out. It triggers a massive TGF response, clamping down the afferent arteriole hard. GFR plummets, creatinine shoots up, and the patient stops making much urine. That's oliguria. If you can get rid of the toxin, the kidney can usually start to heal itself over the next couple of weeks.
And here's what's so incredibly elegant about this whole system. It's bidirectional. We just saw what happens with a high solute load in ATN. The system constricts to protect itself. But what happens in the opposite scenario, like when someone is dehydrated and has low volume? Well, the macula densa senses a low chloride delivery. This triggers the release of vasodilators like prostaglandins and also kicks off renin secretion. These signals tell the afferent arteriole to dilate, to open up, which helps to maintain GFR and keep the kidneys perfused. It's an amazingly adaptive system.
For our last section here, let's just zoom out one last time and put everything we've talked about into a broader context. A really useful way to think about kidney diseases is to categorize them by which part of the kidney is the primary problem.
So you can really organize your thinking into 3 main compartments: vascular, tubulointerstitial, and glomerular. ATN, as we've discussed at length, is the classic example of an acute tubulointerstitial disease. This helps distinguish it from problems that start in the blood vessels, like renal artery stenosis, or problems that start in the filter itself, the glomerulus. It's a really clean framework for building a differential diagnosis when a patient comes in with kidney failure.
So to wrap it all up, this ability of the kidney to regulate itself is nothing short of a masterclass in physiology. It's this incredibly precise, essential system that acts as a shield, protecting the delicate glomeruli from the constant ups and downs of our systemic blood pressure, which is absolutely crucial for preserving kidney function.
But that leads us to one final critical question. As elegant as this system is, it's not invincible. It has its limits. So you have to ask yourself, what kind of systemic catastrophe is powerful enough to overwhelm this finely tuned protective mechanism? What happens in severe shock or when we give certain drugs that can completely break this system and lead to catastrophic renal failure?